The second case is that of a 65-year-old male patient who underwent coronary artery bypass grafting that was complicated by renal failure requiring dialysis, pneumonia, and respiratory failure. The patient had a prolonged hospital stay. The following chest X-ray demonstrated right-sided opacities evolving over a few days. A bedside ultrasound was performed to evaluate the right lung to see if the opacity represented mostly collapsed lung or a significant pleural effusion. As the patient had respiratory insufficiency, findings of a significant pleural effusion would motivate its drainage, while findings of significant atelectasis would motivate a bronchoscopy and potential antibiotic treatment. Scanning was performed in the right lateral chest and started in the anterior axillary line. At such an anterior probe position, mostly aerated lung artifacts were seen. However, moving the probe slightly downward revealed right away the presence of a pleural effusion on the cranial aspect of the diaphragm and ascites on the caudal aspect of the diaphragm. The aerated lung and liver are also well visualized. Continuing to scan downward through the mid-axillary line, the effusion is still seen down to the posterior axillary line where the size of the effusion is maximal with some fibrin septations visualized. Our ultrasound assessment makes it clear that the findings of the chest X-ray are caused by a significant pleural effusion that is going from the posterior aspect of the chest up to the anterior axillary line. It is thus a very significant, somewhat loculated effusion, and in the clinical context of these patients with respiratory insufficiency, dictates that it be drained. Identification of a safe needle entry site and ideal needle angle and trajectory are carefully done as previously discussed, and the patient is then ready for its thoracentesis. The patient is positioned with his arm up and the head of the bed elevated at approximately 20 to 30 degrees. The area where the thoracentesis will be performed is prepped and draped. The pigtail catheter kit is prepared. The intercostal space where the thoracentesis will be performed is carefully palpated, and local analgesia is performed at the exact site that was previously determined to be optimal with the help of ultrasound. The angle of the needle used for local analgesia and subsequently for the thoracentesis itself must duplicate the angle of the transducer used to establish the safe path for needle insertion. A trajectory perpendicular to the ribcage is best, as shown here. Once pleural fluid is obtained, the syringe is detached from the needle and the guide wire is inserted. This will be followed by dilatation and pigtail insertion. If needed, a sample of the fluid can be taken with the help of a syringe and sent for analysis. The pigtail catheter is then connected to a drainage system. Finally, always make sure the catheter is firmly sutured to the chest wall. When comparing the chest X-ray performed before to that performed after the procedure, we can observe a very complete drainage of the effusion with resolution of most of the right-sided opacities that were present. The pigtail catheter is well visualized on the chest X-ray. As was previously explained and demonstrated, in the vast majority of cases in which ultrasound is used for thoracentesis, the needle insertion is not directly visualized, and ultrasound is used to identify the pleural fluid and identify anatomic boundaries and surrounding organs, and finally to demonstrate an unobstructed access to fluid. The needle insertion itself is not performed in most cases using real-time guidance. However, there are instances in which direct real-time needle visualization during insertion may be desired, such as when tapping a small or loculated effusion.